little rubber pieces that go over that. Watch for pressure areas. Watch for signs and symptoms of infection. So it would start getting red around the skin. They might have some drainage coming out of that. That's all going to be a bad sign. We check their neurovascular status every 2 to 4 hours for the first 24 hours once they get this. So we're making sure that they have a good pulse to that area. You have to clean the pin sites, and you clean them separately to avoid cross-contamination. So if you had an order to clean the site with like a Q-tip applicator, you would use a different one for each pin site. So you wouldn't want to, like, if one was infected, go ahead and drag that on over to the next one, infect that. So for some reason they want you to never adjust the clamp. So like, I don't think you would get out your little screwdriver and start screwing it in a little deeper, but just in case, you shouldn't do that. And we want to avoid osteomyelitis, which is infection of the bone. So we don't, that's, you know, if we have a direct source through the skin, the outside, all the way to the bone. So they're prone to osteomyelitis, and osteomyelitis is bad.
How long do they typically have one of those devices on for?
So they'll have these on until it heals. So a lot of times they're putting them on older people. They heal slowly, so they will have to do x-rays and see what the progression of it would be. But it's generally like 4 to 6 weeks. So, and they'll do these on some people who are not surgical candidates. So say you have someone with a bad heart and they don't want to put them under general anesthesia, but they can do an external fixator. And here's another example of an external fixator on someone's wrist. So you can see the break here, and they have this. So traction is a pulling force on extremity to promote and maintain alignment of the injured part. Our goal is to decrease muscle spasms, pain, realignment of bone fractures, correcting, preventing deformities. So what you do is, like, if you have a break and say that they are waiting to go to surgery, we can use traction. And like they broke their leg and the bone's like this, and all of a sudden it's like this. So if we can put traction and pull it straight together, not only are we straightening out the bone, but we're straightening out, more important, is the blood vessels and the nerves, because those are the ones that can get damaged, and they're permanent. You need to know the type of traction and maybe the most common traction used, which in this case would be Buck's traction, and it is used for femur fractures. There's an example of it right here. So what we'll do is put this Velcro boot on their leg, and then there's a string that comes up here, and then it goes to a pulley, and then there's a weight. This picture doesn't show the weight, but just at the bottom of the string is a weight. The weight needs to be off the ground. So if it's on the ground, then it's not doing any good. And what happens is we'll put them on them, and then the weight slowly pulls them towards the end of the bed, and then you just have to take the weight off and then pull them up to the top of the bed. And,
Is that painful?
it is painful
That sounds painful.
when it moves, and sometimes they don't like it. And it's really painful, like when you go in the room to do your assessment and it's dark and you're trying to be all good, and then you kick the weight like I've done before, and then suddenly they scream out, and you're like, oh, that didn't work out too well. So make sure, if you're working with them and it's nighttime, turn on the light, because I did this once and I'll never do it again. But it was on an orthopedic unit they floated me to when I was in resource, and this poor little lady, she was in so much pain, and I'm sneaking in there to do her thing, and it just bam, I just totally kicked that weight, pulled her leg down. I helped her pain out a lot. So know about the traction, and the most common one we use is Buck's traction. There's also skin traction, skeletal traction. And the skeletal traction, they just kind of drill that into the bone also, and then they will have this weight attached to it there. But it always goes over the bed and hangs down there. So if they're on traction, we want to make sure that we're not getting skin breakdown and infections, because that boot, it has to be on tight on their leg or it just falls off. You know, their leg just slides right out. So it has to be on there pretty tight, and if you have something on there tight, then maybe you're impeding the blood flow so they can get skin breakdown. We want to assess for sensation to see if we are causing nerve damage. We want to check their capillary refill. We want to assess their anxiety, let them know that everything's working okay. I mean, the equipment itself looks kind of threatening. They'll need assistance with self-care, such as bathing and toileting. We want to monitor for complications. Some of the biggest complication would be DVT. So a deep vein thrombosis or a blood clot, if they're not using that leg and they're not ever moving it, the blood can pool in there. And we can't really put TED hose on a broken leg. It's very painful. So we have them do foot exercises. We assess for warmth, redness, and swelling. They may put them on a blood thinner if it's going to be a while before their surgery. Compartment syndrome, we'll address this later. Atelectasis or pneumonia, we'll have them do deep breathing and coughing exercises. A lot of these people are constipated because we give them our narcotics and they're not moving around. So we'll give them stool softeners. Urinary stasis and your UTIs. So if a lot of people with this that can't get out of bed and sit up properly will have incomplete emptying of the bladder. So then they're at risk for getting a UTI. This is just showing our 5 Ps and some of the different things with the fracture. When you're reading, if you notice anything about joint replacement's not covered in this class, but we'll be in 110. So. Sciatica is nerve pain that radiates down the back of your thigh into your foot. It can affect their gait. It hurts really, really bad. A lot of times people will get this while they're pregnant or from a leg injury. Has anyone ever had sciatica here? Yeah, did you have it? Some people have it chronically, but when you have it, it hurts and it radiates down the back of your thigh all the way to your foot. So that's one indication for it. With this, they look at some other problems to try to rule out those, and then they diagnose it based on how it's reported to them. How they manage it is weight reduction, which is super easy, doing different types of exercises, or actually having the child if it's from your pregnancy. So a lot of times it's just analgesic and rest, avoiding strains to that area, and using good body mechanics. These are some of the different disorders that we're going to talk about. Carpal tunnel. This is an entrapment neuropathy. So the median nerve at the wrist, it's compressed, and it can be compressed by edema or a soft tissue mass. It is usually done, it's usually younger people, middle-aged people, 30 to 60. It's caused by repetitive movements. So a lot of factory workers get it. People who are doing computer work can get it.
It's horrible.
It's associated with rheumatoid arthritis, diabetes, just trauma to the area. How it presents itself is it can be very painful. It can be numb. Sometimes it's more common to have pain at night. The positive Tinel's test, this won't be on the test, but basically they percuss lightly over the median nerve. They just tap on it, and if it starts to mimic the tingling and the numbness, then that's considered a positive test for that. So what they do is they will release the nerve under local anesthesia. So they'll go in and they will cut the corporal ligament so that this channel's widened. So you can see in this picture here, this ligament is pushing too much pressure on that, and they will actually cut it, and it makes a channel for it. They sometimes use splints, and this will prevent the hyperflexion of it. They use NSAIDs and steroids. Did you say you had this at one time?
Yeah, I used to do data entry sometimes when make bridges and stuff. After doing it all day long, I literally could barely drive.
Yes.
Barely open the door, twist anything.
How do they treat yours?
I just stopped doing it.
Right, yeah.
I'm
So
not doing
stop
it.
doing that.
And then
that type
I
of
mean,
motion.
and I type like a whole lot. It does it as well.
Mhm.
So I have, but if I don't do it, I don't have a problem.
Right, yeah. So that's probably the best thing, is just stop doing whatever's causing it. But if that is your job, think about that. And osteomyelitis, that's infection of the bone. It results in inflammation and necrosis and formation of new bone. So it's 3 different ways. It's hemogenesis, is bloodborne. It's contagious focus, which is it's contaminated, like during surgery or exposure to an open fracture or trauma. So you can get this like a gunshot wound. So the bullet's dirty, and as it travels through and it hits bones, it's actually getting some of those microbes on the bones, and then you can get osteomyelitis from that. You can get it from vascular insufficiency. This is usually our diabetic population, are people with peripheral vascular disease. So a lot of our diabetics will get osteomyelitis. The bone gets infected, and since their sugar is high, they don't heal. They usually have poor circulation to that area, and ultimately results in that extremity being removed. So about half the time it's caused by staph, and some of the staph could be MRSA. It can also be from strep. Initially it's inflamed, it gets edematous. After a couple days, the vessels stop, they get a thrombosis in them, they stop getting the blood supply to that area. So then it gets ischemic, and ischemia is when you're not getting enough blood supply. So the blood is transporting oxygen, so ultimately they're not getting enough oxygen to these areas, and then they get necrotic. Necrotic is when it starts rotting away. So necrosis will come about when you're not getting enough blood supply. So those are some terms that you're always going to need to know. The bone will have an abscess that forms. This abscess, which is like a pocket, it is not strong bone. It contains dead bone and tissue. Then you get new bone that forms around it, but this bone is chronically infected. It causes recurrent infections. It is not a strong bone. But do know that most of the time, osteomyelitis is caused by staph. So how it presents itself, if it's bloodborne, that they'll have signs and symptoms of sepsis, so they'll have a high fever, rapid pulse. The area becomes painful, swollen. It may start to have purulent drainage. So it's got like this green pussy stuff coming out of it. It can't be good. So we'll take them and we'll do an x-ray. We may do a bone scan. We'll do a CBC, and we'll notice that they have leukocytosis, which is elevated white blood cell production. So your body is making white blood cells to try to fight the infection. They will have an elevated erythrocyte sedimentation rate. The ESR just tells us that they have inflammation. If they have drainage coming out, that we will do a wound culture and we'll send that out. And then we'll probably do an MRI to see the extent of the damage. So prevention of osteomyelitis is the goal. Early detection and prompt treatment is required to reduce the chronic infection and disability. So a lot of our diabetics, I don't know if you've heard stories, but we get patients that will have like a giant nail in their foot, a piece of glass in their foot, something that you would obviously not want in your foot, and most people would notice there's something in their foot. But diabetics get neuropathy from the nerve damage. They can't feel anything down there. Sometimes they feel with their neuropathy, it's really sensitive, but the majority of the time they don't feel anything. So literally they're walking around with a giant nail or a piece of glass sticking in their foot and had no idea. And then they don't heal very well, so by the time they find out, they're already starting to break down. So when they get osteomyelitis, the first thing we're going to do is that we are going to try to give them antibiotics. So this antibiotic can be used long term, 3 to 6 weeks. If you don't respond to the antibiotics, or if if the infection is starting to spread, they will have a surgeon come in, and the surgeon will then initially start with debriding the necrotic tissue out, so they'll cut that out. They may have an irrigation system. There's this closed irrigation system. Well, it actually has like a bag of IV fluid, and they leave the tubing inside the wound, and the IV just flows inside their wound, slowly irrigating it. And then sometimes they will use internal fixation to stabilize the bone. And then finally, I don't know why it fell off, but they do amputations. So unfortunately, that is all. If you have a really severe diabetic, it usually ends up that we are amputating. So if it's a foot, a lot of times they'll start with like maybe the toes or maybe just half the foot, and then they may do below the knee amputation, and then if it's still getting bad, they'll do above the knee amputation. They'll take it all the way up. So that's why they tell diabetics every day to look at your feet, look to see if there's something in there. You want to avoid that. Osteoporosis. See, there's like 5 slides that I chopped off right there. This is the most prevalent bone disease in the world. 10 million Americans have this, and there's like 33 million have the osteopenia, which is low bone density. This is a precursor to osteoporosis, so they are on the road to that. 1 out of every 2 Caucasian women will have an osteoporosis related fracture in their lifetime. So think about the person next to you. If it's not you, it's them who are going to break a bone related to osteoporosis. So you just be like, it's not me, so must be you then. So, all right. You need to know who has most risk for this, and it's very prevalent among small-framed, non-obese Caucasian women. So this is one time it's good to be obese, okay? All right? So at least you can say, at least I won't get osteoporosis. So, but small-framed, non-obese Caucasian women are most likely to get osteoporosis. It may be undetectable until there's been 25 to 40% bone loss. Primary osteoporosis is women after menopause and men later in life. And it's due to a lack of peak bone mass and low vitamin D levels contribute to this. Early identification of risk factors is used to help prevent. Secondary osteoporosis results from medication or diseases that affect bone metabolism. Men are more likely to get the secondary osteoporosis. People who use long-term corticosteroids such as prednisone, especially greater than 3 months. People who take excessive alcohol intake, anti-seizure drugs, thyroid replacement drugs, a medicine called Depo-Provera.
Isn't that the birth control shot?
Yes.
So,
Yeah, so this causes a lot of changes in your body, and you're more likely to get osteoporosis with that. Also, people who are greater than 80 years of age, there's like at least half of them have osteoporosis. And you're starting to see a lot of men get this. About a third of hip fractures in men are from osteoporosis. As you get older, you don't absorb as much calcium, and you need about 1,200 milligrams of calcium a day. That can be important. 1,200 milligrams of calcium every day. So when you get osteoporosis, your bone mass is reduced. The bone matrix starts to fall apart, and the bone is the strength of the bone. So I think there's a picture. Yeah, like, so on the right hand side, so this is a good bone matrix. See how they're all connected? And that's like on a microscopic level. But when you get osteoporosis, you start losing pieces of your matrix. So this is not going to be very strong. And that's what starts happening to you. So with osteoporosis, the rate of bone reabsorption, this is where you're taking away the old bone, starts to be greater than what's maintained by the osteoblast. So you're removing more bone than your body's replacing that bone. These people have stress fractures. They're most common in the thoracic, lumbar, and spine. They can also be fractures of the wrist. So these are stress fractures, so they just like wake up one day or sneeze. I can't tell you how many people have told me they sneezed and then broke a bone. So that's pretty bad when your osteoporosis is so bad that you sneeze and break a bone. Or that they were walking down the stairs and they just, on one of the stairs, they felt something snap and they broke a bone. So you gotta be pretty weak bones for that. So your estrogen levels, they inhibit bone breakdown, and your estrogen levels go down later in life. So it's important to keep your hormone levels adequate. Also, your calcitonin levels, they are inhibited. So you have decreased calcitonin levels, and the calcitonin inhibits bone reabsorption. So all these result in a net loss of bone mass over time. This shows us factors that affect osteoporosis. So it's our small-framed, female, Caucasians, postmenopausal or low testosterone in men, decreased calcitonin levels. So nutrition-wise, these are people that have low calcium intake, low vitamin D intake. So a lot of people don't supplement. And you think of, as someone gets older, they're less likely to leave the house as much, to work in their garden, to take a walk, to go outside. Some of these people in the nursing home, when you're there, are white as a ghost, and you're like, I don't think the sunlight's touched them in like 10 years. So people also can have high phosphate levels. And remember, if they have a high phosphate level, they have a low calcium level. It's an inverse relationship. So you get phosphates by carbonated beverages, different types of foods. Just overall inadequate calorie intake. They're not taking in enough food. Sedimentary lifestyle, lack of weight-bearing exercises. So remember how we said you had to use weight-bearing? Weight-bearing strengthens your bones. Some of these people do not get any type of stress on their bones, so their body does not have strong bones. Lifestyle change choices, caffeine, alcohol, smoking, lack of exposure to sunlight. These all contribute to osteoporosis. And then medications would be steroids, anti-seizure medicines, thyroid hormones, A lot of people are on that. So you have a gradual collapse of vertebrae. So this first picture is 10 years postmenopausal. You know, she's still looking pretty good. She's like 5'6". 15 years, so just 5 years after that, they've lost 1.5 inches of height. So the vertebrae are getting weaker, and they're losing, and they're getting smaller and smaller. And then at 25 years, they've lost about 3.5 inches. So a lot of times, like these older people, you'll ask, like, how tall are you? Like, we admit someone, what's your height? And they always say, well, I used to be 5'6". And a lot of them have really shrunk. So
You start losing height, I think, after 40.
I think
A half inch every decade.
right. So just don't get old. Get short. So this is Grandma. Grandma is a drinker. She drinks every night. I mean, a lot of grandmas do. It's shocking to me. They're not all just making cookies for you.
Making cookies while drinking.
They drink. Like a lot of them do. Even my grandmother, she would drink a little red wine every night, but I don't know, maybe a little
My grandma
more.
drinks whiskey every night.
Yeah, yeah. I mean, they do. So.
Good stuff.
My grandma had bladder cancer, I think, and she drank a beer a day because her doctor said that it would help somehow.
So beer like enhances appetite. So it used to be a beer called Pabst Blue Ribbon would be prescribed, and we would actually like get it out, and it was a can of Pabst Blue Ribbon, had like a medical label on it, and we'd like whoosh,
What?
and pour it into. And they gave that as an appetite enhancer for people. I mean, when I used to be in the
You know, when you get the
hospital,
munchies at 2 o'clock in the
we
morning?
would give our alcoholics whiskey so they wouldn't go into DTs, which is far better than what we do now. Today, we let them go into DTs, we restrain them, we drug them up, and then we send them back on the street to drink again. And all we did is just either killed them or kill us or spend a bunch of money. But it used to be that it would be like Jack Daniels, and it would come in a medical bottle. It wasn't in the Jack Daniels bottle, but it would be like dispense 40 mils BID. I just pour them a little shot. And they didn't want to take their other medicine, but they were like, you know, they take that. So,
They'd probably come in there if they couldn't get it done.
and they still give that.
Yeah, I still, I'm a dietitian, and so we still did beer, we still did.
Yeah. For some reason, IU Health doesn't want to do that.
We hand it out.
Yes.
They really don't do
At
that.
a facility I was doing, my KMA training at, they told me that they used to let everyone drink wine on Sundays, and nobody took their medications on Sundays.
Really?
They were just all
Nice.
drunk all day.
Yeah. Well, you know, alcohol's a lot cheaper than some of the
It was a nursing
medications that we
home,
use.
so.
But grandma here, she's got low calcium, low estrogen. She smokes. Kind of looks like she's a little smoker. You know, she's like bent over and she's gonna curse you up a storm here. She uses a sedimentary lifestyle. So these are some of the risk factors. After menopause, your estrogen level goes down. And a lot of these people may have steroid use due to some type of medical condition, or maybe from smoking, they have to be on steroids because they have really bad COPD. So it kind of contributes to this. But these people are at risk for just spontaneous fractures of the hip, of the wrist, and of the back. So how they diagnose this is they will do a bone density study on them. So if you're postmenopausal, they're going to do it at 50. If not, once you're 65, they will be doing serum, calcium, phosphate levels, and ESR, hematocrit, then possibly other x-rays to rule out any other possible disorders. But they usually will try to do a baseline study to see a bone density test to see where you are and then where you are in 5 years. So they're doing it over 5 years. So we will give them calcium and vitamin D supplements. They may give them a drug, a biphosphonate. There's example would be Fosamax. This increases bone mass and tells the body to decrease the bone loss. These drugs, they have to take on with a full glass of water, and they have to sit up for 30 to 60 minutes after they give that, so because it has really severe reflux. Sometimes it gets so bad that they'll have a fracture, and then they may need surgery or a joint replacement. They may have a compression fracture of the spine. They may have to have a procedure called kyphoplasty, and we see a lot of this. So if you can think of the vertebrae collapsing onto each other, and as they've collapsed, they are pinching nerves in between them, and it's very, very painful. So what they'll do is they'll do a procedure called kyphoplasty. So they take a needle and they put it in between the vertebrae, and then they blow up a balloon and they give it a little space. Then they inject a cement. It's like a polymer cement they inject in there, and that gives the space, and it helps that vertebrae. I've seen patients go in just agony, and they go from this procedure and they basically have no pain. But it can also cause problems, because if you've all collapsed and broken down, and then you take one area where there's a problem and you lift it up, you're putting pressure down below, you're squeezing it more, and above you're squeezing it more. So then what ends up happening is they have problems in those areas. So they need to have more done.
They have like muscles tighten up because everything's out of line. And
They'll have muscle spasms with that also,
Yeah.
yes.
Does your body ever see that as like a foreign thing and try
I don't
to-
think they reject it,
Okay.
no, because it's a cement rather than like a foreign object that's in there. But I guess it's something it could be. A lot of these people are on steroids. This is important to know. If they're on the steroids and the steroids are contributing to osteoporosis, you can stop the steroids, and that will stop the progression of the osteoporosis, but it doesn't restore the bone mass. So it just stops it from getting worse, but it will not stop or restore the bone mass. So what we do is we want to prevent it. So you want to, and throughout your life, is you want to eat foods that are high in calcium and vitamin D. Vitamin D is super duper important. They're finding it is, especially high levels of vitamin D. They're easy to take. I don't know if any of you take vitamin D, but they look like little pieces of candy. They're like see-through. And the higher your vitamin D levels are, you're like immune to all types of different diseases. This isn't on the test.